second, third, 4, 5, 6. Okay?
Alex Castellino from Medscape. This is a question addressed to Dr. Ramalingam and to you, Professor. Okay. In Flora, it was a discussion of third generation versus first generation EGFR inhibitors. You showed quite nicely that, with the EGFR inhibitors, you do get a response of 32 months about median survival. And you suggested that this is probably due to a lot of people crossing over to the osimertinib arm. Does that suggest that that would probably be the scenario in clinical practice, where if patients receive EGFR inhibitors first and then osimertinib, that is what you would see? Because the question begs itself, why not give patients EGFR inhibitors, the first or second generation EGFR inhibitors first, and then the osimertinib as the next, so that they can get the best benefits, considering that most of the mutations that are generated with osimertinib do not have targeted therapies yet?
Yeah. Thank you for that question. The results of the FLORA study clearly show that we should give the best agent first. Here is why I say that. 30% of the patients in both arms of the trial did not receive any subsequent therapy after progression, and vast majority of them was because they died. For those patients, the first-line treatment was the only shot that they had. The second point, not every patient develops T790. If you go with the sequencing game, only about 30 to 35% of patients will have a chance to get osimertinib, even if they went on to receive a second-line therapy. So you can either give your best drug first or roll the dice that you will lose the opportunity in 2 out of 3 patients to give a second-line therapy. And this is why we feel that the best drug should be given first.
Yeah, I would add that the possibility to identifying the T790M, it depends on the technique. It's not available in many places. So apart from the number of mutation resistant in clinical trial, in clinical life is even more complicated, and absolutely agree that the first drug should be the first given for patients. And second question for you? Yeah.
Thank you. Caroline Helwig, the ASCO post for Dr. Ray Kokart and Dr. Banerjee. HRD status was important in the results of your study. Should all patients receive this test, and which of the several methods would you recommend?
It's an excellent question. As you have seen, the greatest benefit effectively in this population, and for sure this patient need to receive a PARP. And as we mentioned in our trial, the combination with BEV report a very long progression-free survival. Now to discuss about the test, it's a little bit more complicated for 2 reasons. The first is that in the US and in Europe, the regulatory authorities did not look at the test in the same way. And in this trial, we have used the Myriad My Choice, which is available in US but not available in Europe. And we are working now with the result, but it is very, very recent, to try to define how we can build perhaps academic test or easier accessible test for everybody.
So can you hear me? Yeah, great. So let's learn from the recurrent setting. So in the recurrent setting at the moment, for niraparib, olaparib, rucaparib, it's for all comers. And I think what we've learned is that the HRD tests haven't been good enough to separate those patients that don't benefit from treatment. The 2 studies that I mentioned, so obviously Isabella Cocker's Paola study and Prima used the Myriad My Choice test. What you will hear this afternoon is the results of the niraparib study, which is the Prima study, which will show the efficacy in HRD positive patients and the whole population. I understand there'll be some interesting results about the HRD proficient population, suggesting perhaps we should be giving a PARP inhibitor to all comers. So we really need to understand and see this data in more detail, because the next question is what you've alluded to, is are we ready in clinical practice to deliver HRD testing in practice?
Thank you. Next question for you.
Shriyananda from Medwire News. Question for Dr. Peters. It's not an uncomplicated trial, but then I'm also confused by one thing. Why measure PFS in TMB positive patients and then, or TMB high, and then measure OS in PD-L1 positive and negative patients?
It's an excellent question, I must say. These trials, not only this one, but this frontline immunotherapy trial in lung cancer, have adapted to the incoming knowledge and data over time. So you have been seeing, and that's why they became very complex, some changes in endpoint and strategies. So it's a learning process. So we measured PFS according to TMB because the early trials we have been performing, the Checkmate, another trial called 568 and Checkmate 12, were suggesting that the benefit when you have a CTLA-4 component was stronger in high TMB. So that's why for the PFS. However, the data were telling us that when we speak about overall survival, it came from Checkmate 12, maybe all patients were benefiting, but a little more the PD-L1 positive, and that's why it was chosen. Unfortunately, middle way of this trial, we just saw larger data set showing that PD-L1 is probably not predictive anymore anytime you have a CTLA-4 component. That's why today we make the effort. I will have a slide with biomarkers. And to answer your question about survival, no biomarker is able to select for the best patients to respond. PD-L1 is not a biomarker in that overall survival endpoint. TMB high, TMB low is not, and the combination of both, trying to make, is not. So we don't have any biomarker for ipi/nivo versus chemo in that trial at the end. But we have been moving with biomarker, trying to make precision oncology, which might not apply there, right? We still struggle a little bit with these new biomarkers and to know if they can be predictive, prognostic, or both. So at the end, the idea is really to look at the data, and that's why we present the negative PD-1 cohort, which was not the primary endpoint, but it just completes the picture.
Okay, now it's time, I don't remember, so the one for here, and then you and you, okay.
Hi, Amy Brown from Vantage. A question for Dr. Banerjee and perhaps for Dr. Ray-Cockard. You said one of the key questions remains what to do with patients, HRD negative patients. I mean, has any of the data that you've seen from these 3 trials convinced you that it's worth using a PARP inhibitor in these patients if indeed the test is available?
Yeah. So the key, we're going to learn a lot this afternoon, and correct me, Isabel, but in the Paula-1 study, in the HR proficient, so no deficiency patients, there was no significant benefit. I think the hazard ratio was 0.92 in terms of the HRD negative population. We need to work out how best to coordinate these treatments, whether single-agent PARP inhibitor can be very active for some patients and what bevacizumab adds to this, or vice versa, olaparib, for example, adding to bevacizumab. So the HR proficient, so there's no deficiency in the niraparib study, looks encouraging. So my interpretation of that is that can we get better tests to separate those patients better that don't benefit? But with the current tests at the moment, which would be the Myriad MyChoice test in the 2 studies that I'm aware of, then really the key point is that the most benefit is in those patients with BRCA mutations, whether it be in the tumour or germline, those with HR deficiency. And so when I'm seeing a patient in front of me, I think it would be very helpful to have an HR assay to tell me, so I can counsel the patient to say, well, actually, your benefit is going to be X. We need to think about this with your quality of life and indeed side effects and doses and such. So I do think it's important to get the right HR deficiency test to the patients.
Sorry.
Well, I think that's what's happened in relapse in recurrent disease. So let's see how the community embrace these results, and I imagine that's what's likely to happen.
Yes, I would like to insist on something really important. You will see this afternoon that what we have observed in Paula-1, where the BEV is an active treatment in maintenance, is that in this population of patients with an HRD test negative, the median PFS with the bevacizumab is quite similar to that we observe in the HRD positive population. until now, the HRD positive population has always a better prognostic than the other. And so using bevacizumab, we increase the median PFS, and probably for this reason, the impact of the PARP inhibitor in combination is clearly less than if you use the PARP alone compared to a watch and wait control arm without treatment.
Sorry, in the interest of time, very short question and very short answer also, please. We have time for 3 questions. I ask.
Charles Bankhead, MedPage Today. This is a question about the osimertinib study, but any of the lung cancer specialists on the panel should feel free to jump in. But what have you learned so far from trials of osimertinib about what comes next? Because patients eventually will progress on those. What do you go to next?
The good news is we're beginning to understand the resistance mechanism to osimertinib when you use it in the frontline setting. We also know that when you give frontline osimertinib, you no longer see T790-mediated resistance. We showed data at the ESMO 2018 Congress on the resistance data from FLORA study. And by understanding these mechanisms of resistance, there are already ongoing trials using combination approaches to prevent the emergence of resistance through those pathways. So we feel that with osimertinib as frontline therapy, it provides an ideal platform to develop novel combination approaches that can take us to the next higher level.
Yeah, and probably new tools like liquid biopsy and monitoring disease will allow us to identify different subsets of patients. We probably will require different strategies, not upfront, but at the beginning. No? So next question for you. Yeah.
Ed Sussman, MedPage Today. Dr. Peters, could you sort of speculate as to why you saw a very strong response with the PD-1 negative patients? It seems like this is an off-target response.
Yeah. It's interesting because the story of TMB and PD-L1 in terms of biomarker is a specialty of lung cancer at the time being. We are just kind of the only ones dealing and struggling with these biomarkers. So just to answer this question about how would ipi/nivo work so well, as well, in PD-1 negative as compared to PD-1 positive? So the answer is the biology behind. When you give a CTLA-4 inhibitor to a tumor, you will do many things. I spoke about memory T cells, but one thing you will do also is to induce strongly the expression of PD-L1. So basically, when you give the CTLA-4 component, you just make your tumors being quite equal in the ways they have been created an interferon gamma signature and an initiation of an immune response. So basically, the CTLA-4 allows for balancing the pre-existing immunity to a kind of an average level. Then, potentially, and I still believe that we need to learn more about it, the quality of the neoantigen to be presented might change from one patient to the other one, explaining the diversity. But the diversity is more about the tumor antigenicity and immunogenicity. It's probably not about the present state of the immune system, because CTLA-4 will pretty balance them at the time you give it.
Does that mean you may not have to test for PD-1?
You don't have to test for PD-1 if you use ipi/nivo.
Yeah, one more
PD-L1,
question. You have one burning question for you, okay? And the last one, sorry. Okay.
Lynn Peterson with Trends in Medicine. So we have a shelf full of PARP inhibitors now, and I'm just wondering how, as a clinician, goes back and next week and looks at how to choose the PARP. What do we learn from, what are we learning here at ESMO that will help determine that?
Thank you for your question. The idea is to come back home with the message that patients with ovarian cancer in first-line treatment need to receive a PARP inhibitor beyond BRCA. I think it's the major message we need to go back home. The standard of care for the majority of the patients include bevacizumab, and so now we know that we have the safety and the efficacy to combine both. But for some patients, because bevacizumab is not available or because bevacizumab is not a good option for this patient, some contraindication or other reason, we have also the information, and Susanna speak about PRIMA, that a PARP inhibitor alone make better than nothing.
So just to add, I think, sorry, can you hear me? Yeah, just to add, I think a key question is, can some patients be treated effectively with a PARP inhibitor alone, whereas some need the combination? And that's something that we need to look at, because the trial presented today was all patients had bevacizumab and olaparib was added on. So what about this current standard of care of olaparib being approved in BRCA-mutated ovarian cancer? What does actually bevacizumab add? So these are all questions that we need to dissect.
Thank you. Sorry, I'm sorry. Yeah, but it's not possible to answer this question, sorry.
Okay, so I think PARP inhibitors in the recurrent setting, what we've seen is they're all equally effective. I don't think it's about which specific PARP inhibitor.
Okay, and the last question.
Thank you. Ludwig Berger, Reuters. A question for Dr. Banerjee, also related to the preceding question. Can you speak maybe to the relative merits of choosing the settings in the Paola trial and the PRIMA trial, with or without bevacizumab, and what does that tell you about the usability or relevance of these two studies? Should I be clearer?
Yeah, sorry. Yeah.
You look confused.
Yeah, sorry, the lights are very bright when I'm looking at you and trying to hear you. Yeah.
Should I say?
So it's about the different settings?
Yes.
So they're both in first-line setting. They're both advanced ovarian cancer. So high-grade serous and endometrioid ovarian cancer. There are differences in some of the patient characteristics. In the PRIMA study,
so my question was more about adding or not adding bevacizumab.
Oh, right. So the PRIMA study was niraparib alone, so a PARP inhibitor alone. The Paola study was all patients had bevacizumab with chemotherapy and as a maintenance treatment, but olaparib was added in. Does that make sense?
I'm just going to check what are the relative merits of checking a study with bevacizumab and in another study not.
Okay.
That tells you something about, is it usable, is it relevant?
Yeah, because not all patients will be suitable to receive bevacizumab because of the risks of bevacizumab. For example, some patients at high risk of bowel perforation because of where the disease is. So not all patients will get bevacizumab. And for example, in England, it's patients that are high risk, so have stage 4 disease or have residual disease left behind, because that's where patients had the greatest benefit from bevacizumab. So there are cohorts of patients that at the moment don't benefit the most from bevacizumab, and those patients, as Isabel Ray-Cockard highlighted, would be at the moment getting a PARP inhibitor alone. So there are different populations that may benefit from a combination, and those that would benefit equally from a single agent. Do you want to add anything, Isabel? Or you're okay?
No, it's just you have understand that in the Paola one we have included the majority of the patient in first line, and in the PRIMA the population of patients were selected to residual disease. So it's not exactly the same population, and it is also for this reason that it will be complex to compare the results, because the median PFS in Paola is very high, and this also due to the fact that we have the BEV and we have all the patients in first line with an advanced ovarian cancer.
I'm really sorry, we don't have time for more questions. Thank you for being here, and thank you to the speaker.